Today I'm going to introduce Dr. Mark Lachmann, and Dr. Lachmann's going to be presenting on the topic of PTSD among older adults. Dr. Lachmann is currently the medical lead of Bridgepoint Active Healthcare, a part of Sinai Health in Toronto. He's also a geriatric psychiatrist working with patients in acute care, rehabilitation, long-term care, and community settings, a role that takes him across Ontario. Dr. Lachmann is also an assistant professor in the Division of Geriatric Psychiatry at the University of Toronto. So I will let Dr. Lachmann take it from here. Thank you very much.
Oops. Hello. I will slowly get started and hopefully this will work. All right. Welcome. Now what do? Oh, I go to share. Okay, perfect. Can people see this? All right, good. Thank you. And so it's a delight to be here. I have about 15-20 minutes to talk, and then there's going to be a case. I will share with you that one of the reasons that I'm here and so happy to talk with you is that the first 9 years of my career, I was a family physician working in Moose Factory in Nunavut. So my background is in primary care. And one of my real areas is in post-traumatic stress disorder in older people. And that's not, I mean, it is an academic interest, but honestly, it's a clinical interest because most of the people who I see in the course of my daily clinical work, trauma is a very big part of their experience. And it's something that all of us really need to have a way to understand and think about as we provide ongoing mental health care. Oopsie daisies, stop. Oh, okay. So in terms of disclosures, I do have a grant from CHR, interestingly looking at suffering in the context of medical assistance and dying and how we do that. I once received a small amount of money being on a panelist of the Economic Club of Canada talking about the future of healthcare. And then I received salary support from Sinai Health and the Ontario Ministry of Health as well. Okay, that's that. Bias. Not going to talk about that. Okay. Objectives. We're going to talk a little bit just how common our experience of trauma is. We're going to think a little bit about the cognitive domain of executive functioning and how that's important when we think about a life course perspective in mental health. And that PTSD actually is something which does present in older people, and why it's important to make a diagnosis and how that helps support both patient, family, but also teams caring for individuals. So just for definitions, serious trauma is experienced by seniors in multiple ways, and here are three. The first is trauma experienced over the course of one's life. And the next slide, we'll talk a little bit about how prevalent that is. And by trauma, I really mean life and limb-threatening experiences, also sexual assault, imprisonment, serious violence. So this is trauma that really is shattering to the self and where people are concerned about their own safety in a deep, fundamental way. There's also a literature on the trauma of illness and care. And at one of my very last slides is going to be a list of references. And one of the references there is a book called Damaged by some colleagues of mine, Bob Maunder and John Hunter, that actually talks how our healthcare system itself just doesn't recognize how traumatic the experience is, even to seek care. The other kind of trauma that elders and seniors experience is the vulnerability that we feel as we age. So that as we become more frail, both physically and cognitively and even socially, sometimes that subjective experience of frailty can lead to some internal cues and triggers about, oh, this is a very similar experience to what I myself was feeling 20 years ago or 25 years ago when I was sexually assaulted, imprisoned, something else happened to me. And that can lead people to behave in ways that is actually quite unexpected for them, but then also for families and caregivers around them. So just some level setting. And so not to put too fine a point on it, this is a echo presentation about trauma. So we're going to talk about trauma. It can be difficult to talk about. So as we go through, please, you may want to step out, or it can be very difficult. That's okay. But these are some of the truths about the society that we live in. Trauma is common. 70 to 80% of those over 65 will have experienced at least one traumatic event. And I actually firmly believe this is an undercount, because you can't go through life in the society that we live in without having traumatic event. And also, this statistic is a general population estimate. When we're working with clinical populations, so the majority of people who I've been asked to see, that really is 100% of people. Violence against women is common. And again, these are undercounts really from North American data, some Canadian, but primarily from the United States. So 25% of women experience intimate partner violence, and 10% will survive a rape over a lifetime. And again, these are undercounts. Some of the work that I also do is as a coroner in the coroner's office here in Ontario. And in our work in the coroner's office, we see murder by male partners to women as so common that the word that we use is femicide. And we have an emphasis on intimate partner violence and domestic violence leading to femicide in the work that we do. And I don't know if people remember in Ontario in the late fall of last year, there was a terrible incident up in Sault Ste. Marie where a gentleman took the life of his partner and a number of his children before killing himself. So violence is part of our world, and it's silenced in many ways. First Nations people have survived contact, a reserve system, a residential school system, the 60s scoop and disproportionate incarceration. First Nations people make up 5% of the population and 30% of the federal penitentiary population. In various provincial systems across the country, the provincial penitentiary rate, so people who are 2 years less a day, those rates are much higher. So 60 to 80%, depending on what province you're in, will be First Nations people. The other comment about the residential school system is that there's a lot of work done in the Truth and Reconciliation Commission in Canada over the last number of years. And there is a database at University of Manitoba. If you go Google Truth and Reconciliation Commission Manitoba, you can actually search all the residential schools in Canada, and you can find out, and this is sort of an indictment of the system, the school is listed, as is the community where the school was located, and it'll say the religious order that ran the school. But then the defining feature of the school is the number of children that died in the school over the course of the tenancy. And in the places that I work on the west coast of James Bay in Waha, there's a number of residential schools, and it's quite sobering to see because it lists the names of the children who died and how many have died in those particular communities. So the intergenerational trauma is a lived, deeply connected, and now documented experience. Immigrant and refugee communities, racialized communities, LGBTQ plus, we have a higher rate of physical and violence and assault that's perpetrated, and those are lived experiences of people. And I alluded to this book, that's the reference number 6, that the healthcare system does not account for nor acknowledge the degree of trauma experienced by patients seeking care, leading to poor outcomes and estrangement from care. So the purpose of this slide really is just to level set that the experience of significant trauma is intimately a part of actually our lives and very much our clinical lives. And the silence or the lack of conversation around these experiences, it actually does have real impact when we're attempting to provide care for individuals who are aging, maybe experiencing an onset of dementia, or are frail. From the point of view of definition, when we talk about a post-traumatic stress disorder, the criteria really haven't changed very much over the course of the various iterations of the DSM. Now we're on DSM-5, and it's relatively simple in that A criteria is you actually have had an actual or threatened experience of death. There's serious injury or sexual violence. And this often is not known until people ask about it, and we can maybe talk about that in the discussion. The next is there really are a number of things that have to happen. So you have re-experiencing phenomena. These are intrusions, nightmares, flashbacks. You have avoidance. So if you had something terrible that happened to you on the TTC, the subway, and you say, oh, I'm never going on the bus, I'm never going on the subway again, that's avoidance. There's hypervigilance. So, okay, maybe I'm able to go on the subway, but really I'm absolutely looking around, making sure that nothing terrible is going to happen to me. And free-floating anxiety, so that you're just going about your day, but really you're anxious, and you may have hypervigilance, an exaggerated startle event, and there's a ruminative aspect to that. And this is something which really impacts one's life. And one thing that's really quite remarkable about post-traumatic stress disorder, especially given how common the prevalence of an underlying trauma is in the world that we live in, is that most people, most of the time, can have something awful happen to them, maybe once, twice, three times, and actually then they go about their life and they're able to sort of manage that experience so that it's not something which is seen by other people. And we would not then say, as a psychiatrist, we wouldn't say that they have a mental illness because they're actually able to function. Which brings me to the next slide. Just because someone is able to function does not mean that those traumatic experiences are not part of their everyday life. A big part of our brain is the front part that goes from our ear to our nose, this big frontal aspect here. And one of the key aspects of it that it does, its function, is executive functioning. And that's planning, organizing, sequencing, and abstracting. And you can think of it, we don't often talk about it, but from a psychiatric, psychological point of view, it actually is our inner experience manager. So I may have had some terrible things happen to me, and those things are present in my consciousness. And I'm using the front part of my brain to say, okay, I know I'm safe. I know nothing is going to happen in the elevator. I'm at work. It's a safe place. I know elevators are safe, despite the fact I had a terrible event that happened to me in the elevator. And no one around me, not even my family, my closest coworkers, they may not know, because I'm not sharing that aspect about myself with someone, that I am actually expending a lot of my brain and myself and how I think about things in managing this inner experience. And one of the challenges as we age, we may develop a mild cognitive impairment with some specific impairment in executive functioning. Often that's mild cognitive impairment, vascular subtype, whatever, or a dementia of different kinds where we have impairment in our ability to manage our inner experiences. And that's a time where we actually then may start to demonstrate symptoms. We may have re-experiencing phenomena. We may have nightmares. We may have intrusion. We may demonstrate hypervigilance. We may be afraid and talking about that. Sometimes that's triggered because we may be in institutionalized care environments that we no longer are able to manage on our own. We may be in a hospital bed. We may fall and break our hip and be not able to move. And that inability to seek safety physically can actually itself be a triggering event inside of ourselves because it's reminiscent, it's a cue of what happened during a previous assault, a previous imprisonment, a previous encounter with the police or with somebody else. That loss of safety and the inability of oneself to actually create a safe space can itself be dysregulating and allow for the emergence of a post-traumatic stress disorder. So what? So why are we talking about this? Well, because it's common, the first thing. The second is we work with individuals who are frail and who may have cognitive impairment or psychiatric histories. And if we're able, and this has been my experience, if we're actually able to frame the behavior that a patient is displaying to us, so people sometimes will be angry, upset, maybe hearing and seeing things, they may be re-experiencing, they may just not feel safe, they may be behaving in unpredictable ways. And if that's because of a post-traumatic stress disorder or some other an experience that they're re-experiencing, it's incredibly powerful to share that narrative with a care team and to share that narrative with a family. And I've seen it happen on many occasions where sharing that narrative that this person was in prison, this person had a sexual assault at this particular time, or this person had a terrible immigration experience, actually has changed how the team has interacted with them. There's a great deal more empathy. There's a great deal more commitment to non-pharmacological strategies. And there also is a recognition that sometimes pharmacotherapy can be very, very important and essential and actually fundamental. And I myself, is one of the reasons I'm interested in this particular field, I have been incredibly humbled by, for a number of individuals who have had significant trauma, either sexual violence or in war or immigration experience. These are individuals who we don't have all the tools to put people back together again. And often what we do is work very carefully over time and relationship to allow people to experience some degree of safety. But often, sometimes we lack the ability to alleviate suffering to the degree that we would hope we could. This is a bit beyond the context of this talk, but I do just want to mention it because there's a lot written about trauma, and much of it is very, very good. And the basics of actual trauma therapy outside of pharmacotherapy, which is a slightly separate conversation, but really was outlined most clearly, I think, in a book written in the late 1980s, Trauma and Recovery by Judith Herman. It's a seminal text. It's probably, if you want to pick one book to read about trauma, it really is the book. And interestingly, she just published at the end of last year a sequel, which I'm looking over there. It's called Truth and Repair. And this was her COVID project. So she's now in her 80s, so she wrote another book. And it's a wonderful book that talks about how society itself has an obligation to help support the repair of individuals who've experienced significant trauma. Anyway, great book. But the 3 stages of trauma therapy are essentially, number 1, safety, which is before we begin any psychological therapy, we really focus on the person being safe as much as possible. Having someone tell the story. Some of this falls down a little bit in terms of complex trauma where people have multiple traumatic events, but the basic idea is the same, where we pick a traumatic event that is salient and meaningful to the person, and we work on it over and over again in therapy so that the emotional response is disconnected from the memory response, if you will, and that allows people to have a different relationship to that particular memory. And the third part is reintegration, which really is hard. And that is, now that I have a different relationship to that past experience, how then do I live again in this world? And one of the challenges often with geriatrics and with seniors is the safety part can be really hard to establish and to be safe and secure around. And it also is very, very important. And we really try and focus on that. And this may come up in the discussion, but one of the most powerful things that I like to use, particularly in institutional settings, in addition to medications, is actually music. Because music therapy draws on a particular part of the brain that is all about safety, interconnectedness, and sometimes it can be very, very helpful to try and have people move into a safe space in their own space, even if they are in an institutional setting. These are just some references, and they're included here for you for further reading if you want to think about it. The item number 6 is a very easy read. Item number 1 is a nice sort of life course analysis of post-traumatic stress disorder across the aging continuum. So I'm going to wrap up. I'm looking forward to hearing about the case, and I'm really looking forward to a discussion and conversation. Thank you very, very much for your patience.
Thank you very much, Dr. Lachmann. So right now, if we can, we'll take a few minutes to see if anyone has any particular questions specific to the content of your presentation or around PTSD and older adults in general. So if you do have any questions or comments, please put those in the chat and we'll see if we can't address them. Perhaps, Dr. Lachmann, while we're waiting, I'll ask one question of you, and that's just whether or not you are familiar at all with any of the research that seems to be going on around PTSD and virtual reality as a form of treatment. Is that something that you've come across at all? I don't really know too much about it, but I have seen it in the news. Yeah,
no, it's interesting. I think it depends. So yes, it's interesting. Depends on what the person would like to do. It's a way of having the narrative be constructed in slightly different ways. So it does the same thing that traditional trauma therapy would do. I will say one thing that I struggle with is that much of the work that's written about post-traumatic stress disorder is not actually in individuals who are cognitively impaired. And much of the work that I do, particularly with elderly, is in a reemergence of a post-traumatic stress disorder in situations where there is cognitive impairment. So myself, that's not part of my practice regime, but I certainly am familiar with it.
Okay. So Marie-Lise Vader, do you want to ask your question?
Hi. Just simply, I suspect a lot of us deal with individuals who are definitely dealing with past trauma, but also struggle with dementia.
Mm-hmm.
And I was just wondering if there's any further resources that you know of that can really help speak to that. So I suspect you can't solve all of our problems in the short time span.
No, I think so. The first thing that I think is super important about the question is, again, this emphasis on safety, and that you know, and I'm amazed actually at how successful or how functional people are living in the community in various kinds of supportive or not supportive environments, but are living in the community with a degree of mild cognitive impairment or dementia. And when someone has a significant trauma history that's tacked on in addition to an early dementia, that loss of an executive functioning ability, where the person really struggles to, or they lose the ability to reason their way out of a situation so that they can't convince themselves that they're safe. And what that means is that it's not actually the cognitive impairment, like the dementia, that is the problem. I mean, it is, because it's making it difficult to reason. But the reason that people feel unsafe is the previous trauma. And the way that one works to support that particular individual is not NOT, not traditional trauma therapy, right? It's not sitting down in a room, reliving the trauma, going through the, what it is focusing on practical steps to have that person feel safe. And that may mean more checks from staff in the house. It may mean calling more frequently on the phone. It may mean some very, very practical things that are oriented to have that particular individual feel more safe in their own space. The second part of that question actually depends on, and I'm so biased because many of the people who I see just don't have families. So I'd like to interact with more families, but many of the people who I just don't have it. But if someone does have a family or do have other supports, then sometimes one can work with that larger social team and actually, it actually becomes a family conversation. Because the family often don't know, number one, that something happened to their loved one, or it's not something that people have ever talked about because it's hard to talk about. And sometimes it becomes an opportunity to speak with family or extended support network and just have a series, don't do one meeting, like have a series of conversations that says, you know, we've noticed this about Bob, Sally, or whoever, and we think this is what's happened, or and we really want to focus our care to reduce this person's burden of suffering. Are there things that we can do together to develop a care plan, recognizing that that can be very hard? But often that can be a kind of an approach. And sometimes people do benefit from medications. So there is a role for some medications in helping manage people's symptoms.
Thank you for that. David Kahn, did you want to ask your question?
Well, thanks a lot, Mark. But that was my question, actually, about medications. So, you know, a lot of people with PTSD have many different symptoms and often very intense symptoms. There's often a lot of mood changes and anxiety. And so what's your view of the use, particularly of antidepressant medications, to help with some of those symptoms? In addition, obviously, as an adjunct to other forms of treatment, but
you know, David, I'm really glad that you asked this question because it's one of the reasons that I'm interested. So it is not true that people who have dementia, BPSD, so the behavior and psychological symptoms of dementia, are not post-traumatic stress disorder. What I mean is that there's a literature on not using medications, particularly antipsychotics, maybe some psychotropic medications, in managing BPSD. Someone who actually has a genuine history of imprisonment, sexual assault, all of these things that can impact quality of life, safety, experience, they will benefit from appropriate pharmacotherapy, particularly to help with sleep, to reduce nightmares, reduce intrusions, and some individuals will benefit from an SSRI medication to reduce anxiety and stress and strain. And it can be very, very effective at actually quite low doses. The challenge, David, in my experience, actually is not the cohort of newly diagnosed people as they age. There is a subset of individuals who, again, survivors of horrific sexual violence over the course of one's life and terrible military, awful things that happen in the course of convict or imprisonment. Those are very much two separate populations. And the individuals that have severe chronic, difficult to manage post-traumatic stress disorder, they continue to have a very difficult time as one ages.
I was just going to comment as well. In my experience, a lot of the individuals with long histories of PTSD are on long-term benzodiazepines. Mm-hmm. And when you assess them, you can see that. And not always high dose, sometimes high dose, sometimes low dose, but that brings with it all its own set of problems as a person ages and has cognitive issues and physical frailty and so on. So
100%.
Yeah.
All right, thank you. Lara Nixon, do you want to share your question?
Yes, thanks so much, Dr. Lachmann, for your talk. My practice is with older adults who have experienced all sorts of forms of marginalization, largely related to poverty, serious mental illness, sometimes a lot of them with homelessness. So lots of trauma, and I'm really interested in your comment about creating safety with older people and the challenges around that, as well as any recommendations both at a micro level that we might have some control over in our practice, and at a meso or macro level within, departments and systems and whatnot.
Thank you, Laura. So it's a great question. I think at a sort of smaller, like individual level, or even within the system that one works in, I think actually having this kind of conversation, like the prevalence of trauma, why don't we talk about people are overwhelmed by even this particular kind of conversation, and the fact that it's real. There is a literature that people who've had these kind of experiences, it actually leads to poor health outcomes, leads to homelessness, leads to unresolved grief, all sorts of things that are challenging and difficult. So, I mean, I'm biased. I'm a geriatric psychiatrist, so I think this is important and we need to talk about it. And that would be the first thing, having a conversation. The second is there is a nascent literature, and I say nascent because many years, well, in the mid 1980s, early 1990s, I think there was a lot of hope that this would happen just more broadly. But there is a small literature on trauma-informed care, which is actually, patterns of how one interacts with patients and people who are seeking assistance, really from the moment someone presents or even before. And there are ways to support and do that. I think at the larger systems issue, Lara, I really struggle with this. And there's a memorable saying that if you can choose to be anything in the world, be kind. And some of the work that we do around safety and how we support individuals, I'm constantly amazed when I'm in the emergency room and someone comes in and they're frightened and they're concerned. Is the single most important thing that one does is provide a sandwich, or a safe place. And I think starting at Maslow's hierarchy of needs, like being very, very explicit that we're not a society that has kept people housed, closed, safe. I think really being mindful of how we do that is fundamentally important. I'm sorry, I can go on for days about this, Laura. I apologize.
No apology needed. Thank you. It's very in keeping with my experience and I guess aspirations. Thank you.
All right, thanks for that. M. Manuliak, did you want to ask your question?
Hi, I was just, I have more of a personal, I have a sister who's in her late 70s now, and she's now come and told us she has PTSD. And I'm just wondering, like, for support and stuff for her, she doesn't have any specific experience. Can you have PTSD from just life? Does that make sense? Or is it
Sure. I mean, well, everybody's experience. So firstly, I would not presume to know what the experience that your sister or other family member may or may not have.
For what
so
she's
doing. I would say thank you for coming to talk to me about this. And, maybe there are things that can be done, like, go seek some assistance, either from a family physician, friendly neighborhood therapist. And I think starting that conversation. So I see a therapist every 2 weeks. The reason is because I work as a coroner and I see all sorts of things that I shouldn't see. And that's very helpful for my own personal maintenance. So I think having someone seek assistance and then directing them is important. Kind of the first rule of trauma care is thou shalt not work with trauma unless someone self-identifies and wants to engage with that with you. It really is, you know, something which a person has to sort of seek out.
Okay.
All right, thank you for that. Sylvia Young, do you want to ask your question?
Yes, hello. So yes, I'm an SLP that works with dementia, neurodegenerative, and stroke in the community, and often I do encounter PTSD with people who have aphasia or other communication barriers. So doing communication assisted partner assisted communication, sorry, I'm shy, assisted communication with them can help. The problem I find is that often it's difficult to coordinate and be allowed to be present with the patient in the instances when they are trying to discuss the trauma. And given that some dementia impair communication more than others, plus stroke can be an addition to it, I was wondering if you have any suggestion. I've encountered lots of cases lately where the communication is the main barrier for these people to actually be able to find a safe zone, I'd say. And also whether you would see this similar effects caused by complex PTSD, which I see in the latest question you covered about complex accumulative effects, or if you draw a distinction between the complex PTSD versus PTSD. Or, yeah.
Oh, such an excellent. So I have a whole bunch of comments, but the first is that, you know, teams are really important in providing care. And I think particularly in this SLP world, OT world, like having a team to sit down and talk about, you know, and you being open, I'm very worried about this patient. I think this is going, and I just want to let you know that these are the things that are going on, and maybe we need to figure out how to approach the person. Fine. The second thing is that particularly in stroke, so particularly in vascular dementia, of all the different kinds of dementias for myself, that's actually probably the most difficult to engage with because how one presents depends on where the stroke is. But particularly with a vascular dementia, you know, executive functioning is the aspect of cognition that is often most impaired. So someone's inner experience manager is often just not working in the way that it did previously. In addition to your discipline, communication is very difficult. And I guess my only comment would be, how does one have a conversation with the team about how to move forward? Because I actually suspect that some of the team might be actually frightened of wanting to have a conversation about trauma with this individual, with assist or not, because what do we do with that experience? Or how do they then think about it? But then maybe having a colleague, a geriatric social worker, someone who has some mental health background, be able to sit with the team and say, well, actually, the reason we want to have some of these conversations is actually to work on safety. We may not be doing some of the other things that we would otherwise do. And some of that depends on cognition. And one of the most frustrating things, I think, in the SLP universe or communication is just because someone has trouble with cognition, with communication, doesn't mean that they have impairment in other aspects of their framing. Which is all of me saying, Sylvia, that I'm deeply sympathetic and it's very hard. And I think having a team to actually talk through this with around that particular patient will be really, really, really important.
Thank you.
All right,
And I don't think you can underestimate the fear that a patient may have of future assault or future awful things happening to them if they lose significant function that makes them unable to move, talk, or experience. So if someone had a previous sexual assault or several sexual assaults, and now they're immobilized, this is terrifying. And sometimes having some very simple scripts or way of ensuring safety or just being clear can be very, 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 very helpful.
It is, and they often open up more to me because I can kind of mediate. So sometimes if I can have a joint session with some of the experts, that helps. We do receive training for counseling, but I rather for personal reason to stay away from it a little bit. So it's just more always the issue of consent, because they may open up to me, but not consent for me to share with the team. So those are the tricky situations. But if like you say, the team is very important, and definitely when there is a stroke on top of everything else, that's the kind of the latest trauma that happens, and then the premorbid trauma, and we are not always allowed to target the premorbid history with if it's a stroke approach. So it's always, it would be nice to have a little bit more of this discussion at the higher level and see if we can open up a little bit, because at the end, it is something that it may affect the recovery. So,
Yeah.
thank you so
Teams and
much.
trauma-informed care. Yep.
Yeah, thank you.
Thank you.
All right, thank you for that. We're going to go on to the case presentation now, but I think a good point to end on from Megan Wallace is that all workers should seek out vicarious trauma education, take care of self so we can care for others. So something definitely very important in the work that that we do. So thank you for that comment.